Let's record. Good morning, everyone, and welcome to Montiart. Today, we have the honor of having Professor Martin Andreas from Vienna in Austria. He's going to talk about tricuspid regurgitation and leads. This is a very hot topic in the field, and he is a worldwide expert. He just led a state-of-the-art review with many experts in the field, and we will see what he has to share with us on this specific topic today. Thanks, Martin.
Thank you for your invitation. Very happy to be here. It's an honor for me. So I'm going to speak about tricuspid regurgitation and implanted leads. And this is a topic, as you said, it's quite interesting at the moment. I do have some conflicts of interest that I like to share here. So when it comes to pacemaker implantations, we do have about 3.8 pacemaker implantations per million inhabitants per year, 2.2 ICDs and 1.8 CRT systems are implanted in Europe every year. And we recently published an expert review regarding tricuspid valve disease and cardiac implantable electronic devices to get more information and standard of care to how we treat these patients, because back in the days, those patients were often considered high risk for surgery and not suitable for any therapeutic approach. But nowadays, with the new interventional options, we do have several of those patients undergoing treatment, and we now want to understand what is the mechanism behind that, and what can we do to improve, first of all, treatment plans, and then to improve outcome of those patients. And first of all, it's very important to understand the pathogenesis of the disease. And there are two distinct patterns. One is lead-associated tricuspid regurgitation, which means that we have a tricuspid regurg and we have a lead, but they're not. There is no causal relationship between those two entities. And then there is lead-related tricuspid regurgitation, and there is some causal relationship between the lead implantation and the development or progression of tricuspid regurgitation. So in patients who undergo implantation of an implantable electronic device, a tricuspid regurg moderate is at least present in 7 to 30% of those patients. And of course, this may progress over time. And on the other hand, if there is a lead implant, now we go to the lead-related tricuspid regurg. The tricuspid regurgitation worsens by 1 grade, at least in about 20% of those implanted patients. And leaflet impingement occurs in up to 14%, and severe lead-related tricuspid regurg is present in 4 to 7% of patients. So that's a considerable number of patients affected by this disease. And this is gained from the literature, which has a different number of patients included so far, and that the percentage is varying. But as we see, every study found at least 10% involvement of tricuspid regurg in those patients, and the mechanisms are quite different. So risk factors associated with the development of tricuspid regurg is, for example, the placement of the lead in the apical position, previous extraction of leads, a high number of leads going through the tricuspid valve, and right ventricular dilatation, permanent AFib, or a specific angle where the lead is maybe too short. These are risk factors. And then we do have mechanisms, how the tricuspid regurg may develop. And there are mechanisms related to the implantation, which can be entanglement of the lead in the subvalvular apparatus, or perforation of the lead through the leaflet, or impingement or adhesion of the lead to the leaflet. Then there's pacing related, which means that a chronic right ventricular pacing with a high percentage may cause remodeling of the heart. And then we do have some device-related mechanisms like endocarditis or extraction or scarring, which may be a chronic process after implantation. And we did find, this is a Vienna trial, we did find some also effects on survival. So patients who have a already dilated right ventricle receive a lead and worsens the tricuspid regurg do have decreased survival on the long run in a follow-up of 10 years in those patients. So for us, it was kind of important to understand what is the preferred treatment process. So patients who are young and have a low surgical risk definitely should undergo surgery and receive epicardial leads. But most of those patients do have a high surgical risk, and therefore those patients should either discussed for lead extraction, but typically lead extraction doesn't change too much the tricuspid regurg, so they should either receive a transcatheter valve replacement or a TEER or other procedures. So lead associated TR, it's important to understand if it's early or late after the implantation. So early detection of tricuspid regurg after implantation can be resolved by just changing the position of the lead or removing the lead. But the longer the lead is in, the more likely it's a combined mechanism triggered also by annular dilatation, which comes over time. So these patients do not always improve after lead extraction or replacement. So again, low surgical risk patients should undergo surgery, but if there is a high surgical risk, patients who have a small gap, a central chat, mild tethering should undergo TEER, but patients who have a big gap or severe tethering may be better treated by tricuspid valve replacement, transcatheter tricuspid valve replacement. So when it comes to surgery, we do have now the option to go for also minimal invasive procedures or combined procedures. And importantly, for those patients who have a tricuspid regurg, these should undergo not only the risk assessment with the conventional scores, but with additional scores specifically developed for the tricuspid valve, like the TRI-score, the MELD score, or the CRS score. And during surgery, the lead should be extracted or replaced for an epicardial placement. This is the surgery we did. It's a tricuspid redo surgery replacement. The patient was undergoing Epstein repair of a mild Epstein in 96 and now came back as a young patient. So we were able to do a minimal invasive total endoscopic valve replacement for this young patient. So these are novel options which have to be considered. And we know that surgical results nowadays are better than they have been 20 years ago as the perioperative care improved and patient selection improved. But mortality increases according to the risk scores. And we did an analysis of our 400 patient multicenter registry with the current risk scores. And what we found is that the Euro score is typically underestimating the risk of those patients, and the CRS score is slightly overestimating the risk of those patients. So we believe that to have more than one score may help to get a good feeling for the surgical risk of those patients. This I will go over. So, and just to give you another overview, we are working on novel techniques to improve the number of repair rates also in surgery. If the ventricle is dilated, there are those techniques to have subvalvular adjustments, but also the Clover technique may be something important. This is a video I did the patient some years ago prior to the advent of transcatheter therapy. So whipping pacemaker lead, a severe tricuspid regurgitation. And what we found during surgery, beating heart surgery, was that the pacemaker lead was screwed in the papillary muscle. And it's easily to understand that this was the reason for the tricuspid regurg, and the patient recovered early and was and received a biological prosthesis, but had a good post-operative course. So what is important for those patients is to have intermediate time inotropic support. Don't wean them too early from inotropic support, as they need some days of inotropic support, even if they are extubated. Patients have to have a low pulmonary pressure or need NO during the postoperative period. And some of those patients might require intermediate heart mechanical support like ECMO, RV impeller, or temporary airrod for surgery. This is something we have to keep in mind to search for patients who are maybe beyond everything, is that we should estimate the relationship between the pulmonary pressure and the TAPSE. So basically, if patients have a good right ventricular function, the low pulmonary pressure, they have a good outcome. If the opposite, high pulmonary pressure and bad right ventricular function, those patients have an increased mortality. And then we have nowadays different options to treat the tricuspid valve. And basically, I think that with the replacement options, should be very happy to have this option. And patients who have a coaptation defect up to 7 millimeters probably should go directly to replacement nowadays. These are the systems we have available. The new TriClip system enables better steering by the lateral knob, and also the Pascal system is well suited to repair the tricuspid valve. Typically, something like a Clover approach is chosen, but this may be adapted in a sipping approach according to the morphology of the tricuspid valve. This is very variable, but also about required to the gap lengths. And then there are other valve systems in addition to the Evoque system, the V-Dyne, for example, which may be an option for those patients. And if those patients do have some implantation already in the tricuspid valve and still have severe tricuspid regurg, there are some experimental therapies like the Tricento valve, but also rather better established the Tric valve system, which has two Caval valve systems, and did show some impressive reduction of volumes already in this system. So in conclusion, echo assessment prior to and after pacemaker implantation seems to be an important new issue. Early pacemaker revision may resolve TR if it's new, and late stage lead extraction may not affect TR progression. Surgery is a well-established treatment option, and those patients should be referred to specialized centers, and transcatheter options are rapidly evolving and should be applied in high-risk patients. Thank you.
Thanks, Martin. This was a excellent talk. You covered almost everything. Now we can start maybe with some questions from the audience. Maybe I'll start asking you something. I wanted to know, what's your perspective? We know that the HRS consensus document is now recommending lead extraction before any Caval valve implantation. Now they're writing the new consensus. I don't know if this will apply also for transcatheter replacement. What do you think about this? Should we extract all the leads? Should we jail them? What's the best approach?
Well, I know that this is a vivid discussion, and I was invited to work on another expert consensus initiated by Becky Hahn regarding the management of those patients, not only for Caval valves but generally for lead extraction. And I think it's very important to know that lead extraction does have specific risk factors for severe complications. So when it comes to lead extraction, there are some specific risk factors which help us to understand the risk of lead extraction itself. So if the lead is in, for example, 3 years, and you have 3 leads, it's probably reasonable to extract those leads, put in a micra if the patient is fine for that, then go for Caval valves. If the lead is in for 25 years, severely calcified, and there is a high risk of having a Caval bleeding, I would keep the lead in. So I don't think that we have a general extract or not thing. And I would really recommend to go also to this paper, because there are some risk factors having a a five times an odds ratio of 5 to have a severe complication for some risk factors. So I would really argue to not to extract if we have calcified leads, if we have leads in there very long. Those patients are super frail. Sometimes the tricuspid regurg gets worse from extracting, and those patients are definitely no surgical candidates if they go for carval valve. And if they have a bleeding, basically they cannot be saved, to my opinion.
Yes, I agree. And all the field of transcatheter tricuspid valve intervention is new, so I guess things will probably change in the future. Now, a lot of discussion is about how to implant a pacemaker after tricuspid valve replacement. But we also know, we did a study here in our population, we saw that in patients above 75-year-old, we have at least moderate TR in 1 every 5 patients. So it's like it's like the most common valvular heart disease. Do you think that this is a speculative question? Do you think that in the future also the approach on like implanting pacemakers will change, and we will change the way we are pacing our patients?
Yeah, so we generally consider the implantation technique is highly relevant for avoiding tricuspid regurg or progression. So it's important to use the so-called prolapsing technique to enter the right ventricle with a loop before you follow with the lead. So you should not go with the tip of the lead into the right ventricle directly, because this is highly susceptible for entanglement in the subvalvular apparatus. If you enter the right ventricle with a loop, you cannot really entangle. So this is something which should be done in all patients. And then if patients have previous surgery like tricuspid repair, we tend to use a coronary sinus lead alone for those patients to avoid the tricuspid valve completely.
Thank you. I'll
I
stop here.
think one of the questions from the audience is really important. Something I thought about a lot, and I'd love to hear your opinion, Martin, and maybe I'll share my opinion too. So the Ankur asked, thank you for your talk. I was wondering if we should be routinely screening our patients for TR after lead placement. If so, how often?
Yeah, I think the consensus of every meeting I was in was yes, we should, but we don't have the resources. So basically, everybody who is thinking about that says yes, we should do an echo after lead implantation. But this is hard to implement in clinical routine.
Yeah, I mean, there's so many pacemaker leads that are being placed annually. And I guess that's the challenge, right now, even in academic centers like ours, nobody gets an echo after lead placement. I mean, ideally, the echo shouldn't even be after lead placement, it should be in the lab. But the problem with doing it in the lab is they're lying flat. And then maybe when they stand up, the lead position changes. So, there are companies now, just so you know, who have asked the question, Ankur, working on ways to try and promote lead placement in the correct place. Because I think a lot of us believe it's an unmet need, because if we could routinely make sure that the lead crosses in the posterior septal commissure, I think we'll have less issues. The problem is when the lead is attached, it crosses more central, it then starts pushing on the septal lead, or like Martin said, is when it gets entangled in cords and starts interfering with the subvalvular apparatus, it becomes a real challenge. We also had a case, talking to Yogi, we had a case last year, Martin, where a lead was extracted and the whole papillary muscle was ruptured and pulled completely off the side of the wall, because you can't always predict, but I also think one of the things that even our lead extractors are realizing is that you need to now also incorporate advanced imaging if you're going to remove a lead, because not all leads are placed in the same place, right? And so this lead, if you maybe had done a CT on it beforehand, or TE, you would have seen it was completely entangled in the papillary muscle and embedded in. So the chances of it being removed were almost zero. That's kind of predictable. So I think we have to try and incorporate things we've learned elsewhere in intervention, also now in EP.
Yeah, definitely. You're fully right.
Andrea?
Yes, let's see if the others have questions before. Pier Pasquale, you have a question?
Yes, thank you so much for the talk. I was just wondering, as far as the procedural techniques are concerned, let's say we have a patient that we end up deciding that we're not removing the lead, we are trying to treat TR percutaneously. What do you think are the most important consideration as far as steer, but also TTVR is concerned? Do you think any kind of TTVR designs are a little bit more at risk of a optimal post-procedure result if lead is present or not? I just wanted to know your thoughts.
Well, very important question. Thank you. So if it comes to TEER, it's important to understand if the lead is connected to the leaflet, and if yes, where. And then typically one device next to the lead is sufficient to and can be placed. One issue is shadowing, definitely. If there is a lead or more leads in place, echo imaging gets really hard sometimes, and eyes may be required to have good imaging. And by the way, this is true also for TTVR, especially with the Evoke system, where you also have the anchors. And I did a case, I think, 2 weeks ago, where I had some issues with getting the implantation went super nice, but we were unsure about one anchor the whole procedure because it couldn't be imaged nicely. But as the others were fine, it was no problem, and we still don't know. But definitely, it's not only about device selection, but it's also about imaging, and you should have a backup plan, because we know that Evoke has about 25% pacemaker rate de novo. So if the pacemaker lead gets dislocated, or on the long run, so one risk factor, of course, is you have a dependent patient, you implant the valve, the lead gets out, so patient is asystolic. So prior to implantation, you should check if you can paste the right ventricle via the guide wire, via the Safari wire. So this is one issue which should be kept in mind. And the second thing is, so we have everything ready, and before we release the valve, we check if we can paste the ventricle. And the second thing is, of course, sometimes it comes evident after implantation that you need pacing. So we have also seen patients receiving a leadless system after Evoke. This is something we will see more and more.
So always
Thank
staying
you.
on the same topic, let me ask you this question. We always talk about implanting a pacemaker after, especially TTVR. We have Micra, which are great options, also a coronary sinus. It seems that stimulation is being abandoned by our EP colleagues. But what about a patient requiring an ICD lead? What do we do in that case?
The literature says you can place an ICD lead in a coronary sinus, or you can place an ICD lead in the azygos vein or in the somewhere. But I don't think this is a very exceptional thing. I think there is a company having a subcutaneous pacemaker. I think that's a good option, actually. A subcutaneous ICD, sorry.
Yeah, I think we're going to see a lot more of those. There's a new company doing it. I think Andrea, in our hospital, Dan Pugliese is going to start it this month or next month, the first cases. So I think it's from Medtronic, actually, if I'm not mistaken.
That's correct. That's the second one from Medtronic.
Yeah. I saw Manaf on. I'm not sure if we lost Manaf. And just checking if there are any other questions from the audience and from our participants. No, I don't see any other questions. So, I mean, I'll say, Andres, in the US, this issue of jailing leads has become quite a huge discussion point, particularly raised by our EP colleagues. They were very concerned about the fact that we jailing leads, and their concern is twofold. The concern is, will the lead be damaged, and will the impedances change with time? which is which is one issue, which I guess you can always replace the lead. But the second really is the risk of infection of a lead. If a lead becomes infected, you're not going to be able to remove the lead. So I wanted to ask you, since you are a surgeon, I'm not sure everybody was aware you were a cardiac surgeon as well as a cardiac interventionist, structural interventionist. But you in your practice or amongst your colleagues, I'm sure you guys have done tricuspid valve replacement in patients with a pre-existing lead. And as far as I'm aware, for years, surgeons have just sutured their valve and sutured the lead outside the valve without minimal concern. Why do you think there's all this concern now?
Basically, this is something surprisingly we always never did. We always used epicardial leads in our practice, but I know it's done widely across Europe and probably US to just keep the lead inside, because surgeons maybe don't want to deal too much with having the pacemaker impedance testing. It adds up 10 minutes to the procedure. But what we did in our practice, as we always do the pacemakers also ourselves, is we just, everything is removed and we put epicardial leads on. Yeah.
Okay. And have you ever had issues removing the leads, epicardial leads? I mean, so removing the leads, because some of them may be there 10, 12 years, right?
Yeah. So it's much easier. As you have seen the video of the case, we don't try to get everything out. We just cut the lead when it enters the muscle.
Okay.
Because why should you risk that? So if it's not infected, you just cut it where it enters the muscle. You don't pull the muscle out. It's no reason to do that.
Okay.
And by the way, this is something we will see maybe in the future as we have new systems that we may not remove everything. We just want to keep the heart intact and want to get the valve clear of the leads. Because if they are infected, typically they are removed easier, because they are, if they get infected, they have those bacteria all over. It's a different story.
Okay. Before Manaf, you had any questions? I had a couple of other questions for Martin.
Yeah, thanks so much for a great talk. While on the topic of surgery, I just wanted to know, in your center, where in your algorithm does tricuspid valve surgery fall? I know that when we look at data about isolated tricuspid valve surgery, often we see these very high mortality numbers, and for example, at our center, it's rarely done. So how important do you think the local center's expertise is in doing this? And in your center specifically, where does surgery enter kind of the frame? What kind of patient, what kind of tricuspid regurgitation does it fall? Thank you.
So the patient, the center needs to be, I would say, a very experienced referral center, because those procedures are rare, and there is no center having a high number of those procedures. So you need to have a center where you have experience with it. And what helps is to have experience also with assist devices, because typically what we're doing is if we're implanting LVAD, then we have a bad right ventricle, we implant an RVAD system for some days, and this helps the patients coming over that. And it's not only the surgical experience, it's also the experience of anesthesia, how to deal with right ventricular dysfunction, which is related to some days only. So it's not a problem which is a lifelong problem, but you have to get over this deadly period of the first days. And those patients, they don't go down with the arterial pressure, but right heart failure leads to some organ dysfunctions, and then it's a high mortality, and it starts early but silent. You don't see it, and if once you see it, probably you're too late. So you have to be very aware about right heart function, and don't go off inotropic support too early.
So Martin, I mean, can I ask, you guys are an expert center, just to give us a sense, how many isolated tricuspid valve surgeries do you guys do a year?
Yeah, about 10%.
Okay.
So that's
about 10, that's already probably 3 times as much as the average academic center in the United States, where it's, I think, 3 or 4 in general. And when I was looking at your data, I mean, that you showed earlier, I mean, the mortality rate is lower than we see in the published literature. So I think overall, I saw about 5.9% or 5 point something, below 6% overall, putting repair and replacement together. It's a lot lower than we see from the STS registry in the US. So I guess I'm going to have to assume a lot of it is also patient selection. I mean, obviously, there's a lot goes into pre and post procedural care, but a lot of it is patient selection. What is the average age of your patients undergoing isolated tricuspid valve surgery?
Yeah, that's a very difficult question. I would rather say we have to analyze IV drug abusers in a specific category
Separately, yeah.
Because those patients they are young, but they have a very high risk of mortality due to maybe going back to their addiction. Even if surgery goes well, and typically those patients are young and they recover, but then maybe sometime they get a reinfection or something like that. So those patients is a specific category. The other category is very variable, and there are those patients having a young, maybe having an Epstein, mild form of Epstein. So we have some of those, as we have a pediatric program coming in their 40s with Epstein disease or an ASD with a tricuspid regurg. They can be treated with quite low risk though. But then if you have those failed long-term tricuspid regurg due to multiple leads, maybe failed TriClip, these are very high mortality, whatever you do.
Yeah, because the challenge is I look at the paper from Jana Chikwe and colleagues, which is probably the most recent paper looking at outcomes from the STS registry and the most recent data. And their paper, they excluded endocarditis because I agree, that's just a completely different group of patients with different outcomes. And even after excluding endocarditis, right? They still had over 6,000 patients in this paper, so a lot of patients. When you looked at the age of the patients, the average age was around 60 to 65, which is very different to what we're treating with transcatheter techniques, where the average age is 80. If you look at Triluminate and Trisend. But the mortality was still for replacement in the range of sort of 9 to 10%. So it has not changed, right? For repair, a little lower. But the other thing that surprised me was, I often hear that when I speak to surgeons who tell me their outcomes are better, they say, well, I do it beating heart. And with beating heart, I can really decrease mortality. And in this large STS registry, the mortality was actually higher for beating heart than full cardiac arrest. So again, I'm just surprised about how much heterogeneity there is in the data, and as to like what's really, when we compare and we look at different data sets, we're comparing such different groups of patients that it's hard for me to say, okay, one therapy is better than the other, or this is what we need to learn from this study. I find it quite challenging.
Yeah, I agree. I think that's the main issue why we do need expert centers, because there is no golden rule.
Yeah, absolutely.
And it's also related to the experience of the center. And basically, what I try to do is what is happening in reality. So there comes a patient with an intermediate to high risk. So I screen for every interventional therapy, and if there is no interventional therapy, I reconsider surgery. That's the typical way of doing it.
So let me ask you this. In your center now, you have repair, you have replacement. We know what these outcomes are. Say you have a 63-year-old patient, okay, who's not high risk, maybe a little overweight, and you look at the valve and it has large gaps. So it's maybe not a TriClip candidate. In your center, do you offer that patient percutaneous valve replacement or surgical repair?
Is it a patient with AFib?
Yes.
And is the right ventricular function good?
Fine.
I would go for surgery. Put a
Okay.
clip on it. Important. Put a LAA clip on it. Maybe for a mace.
Okay.
Reduce the risk of stroke.
Okay, good. Andrea, I'm not sure that I share that, but because again, I just keep looking at all the data, and I guess you know your own data from your center, and so you know what the outcomes are from your center. But when I just look at the published data for a patient like that, I'm just not sure. I understand what the true mortality is to tell the patient from that procedure.
So that's true. The true mortality is very hard to estimate. We know from the literature that there is a difference in, at least for the mitral, there is a difference between atrial or ventricular functional valve disease. Yeah, so this may be true for the right ventricle. And what I can say in addition to that is, if you go for transcatheter tricuspid valve replacement, you have a 25% risk of pacemaker implantation, and you should be on warfarin for 3 months or longer, and then you need a NOAC. Whereas if I go for surgery, and if I'm lucky, I can go back to sinus rhythm, have an atrial appendage closed, and maybe need no anticoagulation at all on the long run. So this
if
is maybe
if you can repair the valve, yeah, and get a good repair.
If I can repair the valve and get a good repair and can get over the 30 days, I might have a significantly improved long-term prognosis of this 63-year-old lady.
Yep, absolutely. So Martin, I wonder sometimes, having worked both in Europe and the US, how practices are different. Do we have European data for repair versus replacement, the tricuspid? Because all the US data so far continues to show that in patients who have isolated tricuspid valve surgery, majority are having replacement. So 60 to 70% are having replacement rather than repair. Now, I don't think that's because the surgeons are bad surgeons. I just think because the patients they're operating on have more advanced disease, right? And so maybe the valve's not repairable. But I also wonder, is there a philosophical difference in how we approach it? So do you know if there's any European data on what's the rate of isolated repair versus replacement?
Well, I tried to find, we have one registry where we included those, so I can show you this one. I tried to find it at the moment, but typically it comes back to the philosophy, I would say, in Europe is to really repair whenever it's possible, and this is Dreyfus and other centers are really active in repairing the valve. So there is no, and because they are saying since decades that the risk is so high if you replace it. So that's something every surgeon seems to know in Europe, that if you want to get out of the OR, try to repair the valve. So, but this is not for an endocarditis case. This is just for a conventional tricuspid regurg.
Absolutely. Andrea, I want to leave you with the last questions and comments in closing.
Yes, I have just one last question for you. So let's say similar patient as before, 60, 65. In this case, we have severe RV dysfunction, and the valve of this patient needs to be replaced, either surgically or in a transcatheter way. Other than inotropes, do you prophylactically use a mechanical support device? And if so, which kind of device do you use?
Prophylactically, it's a difficult question. So what you could do is to use inhalative nitric oxide, the NOx box, to reduce pulmonary pressure. You can use other medication to reduce pulmonary pressure. And if you see when you try to go off pump that the right ventricle is suffering, you can decide between ECMO and temporary RVAD, which basically is a graft sewn to the pulmonary artery, getting out of the thorax, and the conventional ECMO cannula. So you don't need an oxygenator in this RVAD system, which is good because you keep the thrombocytes alive. and you don't need to reopen the patient, as you can just cut the graft and put it back in the thorax. So this is something we do for the LVADs. We don't have bleeding because we don't have an oxygenator, and you don't have an arterial access, so you don't have an increased stroke rate. So this temporary LVAD concept is pretty, I would say, interesting in if you're used to it, to reduce the downsides of ECMO complication.
Excellent. Thank you so much. I think we can close here at this point. I don't see any other question from the audience. So, Martin, thank you so much for accepting this invitation. It was a fantastic talk and great discussion, and we really hope to see you in the future again.
Thank you so much for your invitation. It was a pleasure.
So much,
Thank you.
Martin.
All the best.